morning, respected faculties. I'll be presenting my two short cases today. First short case, patient Mr. R, 17-year-old male, hailing from Rajapuram, Kolhapur, doing his inter second year, resides in an hostel. Date of admission is 16th of August. Informant is self and mother, both are reliable. He presented with chief complaints of multiple papular lesions in bilateral lower limb, buttocks, hands, and in web spaces since 3 months. He also gives history of low-grade fever and swelling of lower limb since 12 days, reduced urine output and shortness of breath since 8 days. History of presenting illness: 17-year-old college-going student resides in a hostel without any known comorbidities. Noticed multiple papular lesion in bilateral lower limb, which he neglected, slowly progressed to involve groin areas and also including hand, even including web spaces, associated with excessive pruritus. There is no history of discharge from these lesions, not associated with rashes, did not receive any treatment for above complaints. He also gives a significant history that his hostel inmates also have a similar lesion, and throughout this period, other than these complaints, he was asymptomatic. Now he presented with low-grade fever since 12 days, which is continuous in nature, not associated with chills or rigors. It reduced on taking paracetamol. He developed sudden onset swelling, progressive in nature. First, initially started with bilateral lower limbs, involving up till knee. He also complains of facial puffiness since 10 days. He also gives history of reduced urine output. Initially, he says he used to pass around 5 to 6 times per day urine. Now reduced to 1 to 2 times per day. He also complains of shortness of breath. There is no history of orthopnea or PND. There is no history of cough, chest pain, palpitation, no history of loose stools, vomiting, no history of cola-colored urine or burning sensation during micturition. There is no history of increased micturition during night, and there is no history of frothuria. There is no history of indigenous medicine intake or excessive NSAID intake. There is no history of joint pain, stashes. There is no history of altered sensorium or seizures. There is no history of pain abdomen or no history of sore throat. So for above complaints, he was admitted in a local hospital and was told to have reduced renal function in the form of increased serum creatinine, and also he was told to have increased protein and blood leak in the urine, and he also says that he received IV antibiotics and fluids during his hospital stay, and he was referred to our hospital for further management. He was admitted on 16th of August, and after battery of investigations, he underwent 1 session of hemodialysis via right internal jugular vein non-tunnel catheter. Coming to past history, there is no significant past history or no history of any previous. Not yet, no. He was admitted on 16th. Family history, there is no similar complaints among family members.
1 session of hemodialysis he underwent. When did you examine the patient?
17th evening.
So you don't know the present status?
No. It's approximately around 400 ml. There is no significant past history, ma'am. Family history: he was born to a consanguineous married couple. His second in birth order, and there was no history of any NICU admissions or. And birth weight was around approximately 3 kgs. Normal developmental milestones in par with siblings, and normal scholastic performance in par with his peers. So coming to, shall I summarize, ma'am?
Complete your examination by just a short case, ma'am.
How did you find it?
We only important.
Patient is conscious, coherent. There is significant fetal edema, bilateral pitting edema. Blood pressure is 126/80 in right arm supine position. There is depigmented macular lesions in bilateral lower limb, buttocks, and groin area. There is also darkening of skin from groin till mid part of the thigh, probably tinea cruris. There is also papular lesions in interdistal space in bilateral hand. Otherwise, no other positive.
Respiratory system.
All the other systemic examination is normal.
So what is your syndromic diagnosis here?
My syndromic diagnosis would be rapidly progressive renal failure.
That's all.
Second might be acute nephrotic
Do you
syndrome.
want to qualify further the diagnosis of PRF?
due to either IRGN or my second probable diagnosis would be IgA vasculitis or cutaneous lupus erythematosus with lupus nephritis in last down and
Now,
last.
can you call this RPGN as RPRF as RPGN?
Yes, ma'am, because he's requiring dialysis and also there is a significant history of reduced urine output and proteinuria.
RPRF due to RPGN.
Yes.
Now you have to say the diagnosis DD for RPGN here. That will be your IgA, IRGN, lupus, whatever.
Yes.
So that should be the pattern of your diagnostic.
So you want to keep only, you said IRGN, IgA vasculitis and lupus
Yes.
with cutaneous involvement.
Yes.
Only these three.
Yes.
You don't want to keep any other than that.
No, so because there was papular lesion, like purpuric differential diagnosis are ruled out, sir.
You ruled out
Yes.
that. But does the absence of purpuric lesions rule out other possibilities totally?
No, sir. No. It can be the skin lesions can be a different entity, and this
You
renal.
already said
Yes.
linear fluid.
Yes. Yes.
So
Yes.
that could be separate,
Yes.
and that would mean the skin lesions may not be in any way connected with the kidney.
Yes. Yes.
So would you like to add anything to this list?
Um, can be TMA due to
You don't want to think of any other small vessel vasculitis?
can be post-immune vasculitis, but
Should I-
age of presentation.
The age is relatively uncommon,
Yes.
but not impossible.
Yes. Yes.
How does TMA usually present?
There will be significant thrombocytopenia, ma'am, and it can either present as AKI or RPRF. Polyp. Yes. Yes.
Thrombocytopenia and what else? Hematologically anything else?
There will be signs of hemolysis like raised LDH, haptoglobin will be to
Microangiopathic?
microangiopathic hemolytic Maha features.
That's a really important
Cystocyte.
Any other differential diagnosis with RPGN and skin lesions? How does cryoglobulin present?
Usually it is most common in elderly population. No?
That's right.
There can be palpable
Skin
purpuric
lesions
lesions along with renal failure, no? Including
Like clinical
Yes,
present.
yes.
Also possible.
Yes.
How will you define an RPGN?
There will be clinically there will be
Patient should have features of AGN.
yes,
How do you
nephritis.
define AGN?
Significant history of cola colored urine with
Is it must that
hypertension
patient should have a cola colored urine?
in acute nephritic syndrome, no?
Do you have a
No.
gross hematuria always?
No, ma'am.
Need
no.
not.
No, need not.
So micro or macro hematuria must.
Yes, yes.
What are the other components of acute glomerulonephritis?
Hypertension, anasarca, and oliguria.
What percentage will have hypertension? Is it universal?
Not universal, ma'am. 80% will have hypertension.
So features of acute glomerulonephritis plus, and we will say it is rapidly progressive.
If in histopathology, if there is crescentric,
Clinically.
Clinical.
clinically requiring dialysis.
Yes, they
How
always,
much time? You know,
Within
rapidly
yes,
progressing.
yes, yes. Within a span of weeks, there will be
span of,
more than 7 days. If it is less than 7 days, it is AKI. If it is more than 7 days,
how will
then
you define
within
rapid progression? Anybody?
It requires two components, ma'am. The
Hmm?
nature, it has two components, the nature and the tempo. Nature is sitting
Doubling
at
of serum creatinine,
tempo is rapid deterioration of the GFR.
How much time?
50%. More than 1 week to less than 3 months. Or more than 2 weeks to months.
Halving of the GFR or doubling of the serum creatinine within a period of less than 3 months. Because more than 3 months becomes CKD.
so doubling of serum creatinine over a period of 3 months. Usually happens within days to weeks, but still, for definition, it is 3 months.
3 months. That is what you will do.
Yes, please.
TDJ is not a component of
Can be, sir. Will be, should be.
Glomerulonephritis.
Is nephrotic proteinuria common? What percentage will have?
Percentage, I'm not sure, ma'am. Nephrotic will be less, subnephrotic will be more common.
Less, more is
More than 1 gram will be.
less or more? You should tell me percentage.
Subnephrotic will be more common compared to nephrotic range proteinuria.
what is the classical clinical prototype of
Anasarca with oligoanuria.
He has prototype.
In other words, infection, what infection?
Post-streptococcal glomerulonephritis.
What is the change in epidemiology now?
Now,
Is it streptococcal skin infection more common now or something else?
Staph.
Yes.
Why the terminology of post-streptococcal has been changed to infection-related GN?
One, because glomerulonephritis can occur with ongoing infection, ma'am, which is more common in staph. And
Organism other than strepto is now more common, so that is how terminology has been changed.
You know of any other infective disorder where the infection is active along with the glomerulonephritis?
Scrub typhus, malaria, leptospirosis.
Bacterial infection?
Endocarditis.
Yes.
Infective SABI. Yes.
Ongoing infection with the glomerulonephritis, and you treat the infection and the glomerulonephritis can resolve.
What is the classical histopathological variety in bacterial endocarditis associated GN? Prototype renal lesion. Anybody?
MPGM is possible.
Focal proliferative GN. That is the prototype glomerular. Any variant can happen, but most common and prototype is focal. How will you further investigate this child, this boy?
First, blood investigations.
Why do you want blood investigation?
First, to rule out, because there is skin lesions, ma'am. I want to rule out anemia, thrombocytopenia,
Okay.
and
Rule
if
out,
there is
MAHA.
and if there is ongoing
Any
infection,
other
if there
indication for blood routine here?
signs of MA and liver function tests.
Okay, MAHA ruled out.
Yes.
Then?
The
Any
autoimmune
other
profile,
information from blood routine?
serological investigations.
Blood
AMA.
routine, CBC. Patient had some skin infection, etc. You want to rule out a sepsis also?
Yeah, yes,
Isn't it?
yes,
Okay.
blood cultures.
Then,
And serological investigations to rule out
what
autoimmune
serology
etiology.
first?
ANA,
First of all, ANA?
C3, C4, complement
C3, C4.
levels.
Okay.
Yes.
Expected C3 if this is IRGN?
C3 will be low, C4 will be normal, but initial stages of IRGN can
Both
have
C3
C4 or
and
low.
C4 are low.
It can be lupus nephritis or cryoglobulinemia, or it can be because of SABI.
What will be the serology in endocarditis?
C3 will be low, ma'am. Initial stages, both can be low.
Both can be low initial stages. Now, C3 is low, patient is on dialysis. How will you go about further?
Then I will look about other autoimmune etiologies like ANA, DSDNA.
Because
to
it has
diagnose
some
the
skin
person.
lesions and
Yes.
RPGN,
Yes,
agreed?
yes. And because he gives a history of significant lesions in interdigital spaces, I also want to rule out scabies at first. No?
First diagnosis is scabies here.
Yes.
Mm.
And
Will you plan a kidney biopsy at this point of time?
after stabilization, ma'am.
Okay. Tell me a typical histopathological appearance in this boy, if this is IRGN.
Because he is requiring dialysis, I would suspect crescentric.
Can they have severe renal failure without the
Crescents.
Yes, ma'am.
Why?
So in that
Tubular.
in that case, what will the biopsy show?
Show.
No crescents. What else?
What is
It
the
can be
typical-
TMA.
What is the typical description?
Histological description.
Of IRG.
Proliferative
Before that,
endocapillary hypercellularity, diffuse endocapillary hypercellularity.
endocapillary proliferative PPX, diffuse proliferative exudative.
Neutrophil predominance will be there.
So that can be there without crescents.
Yes.
And yet the clinical picture is like this.
Yes, yes.
Histologically, what terms you use? Diffuse, focal, elaborate one.
Yes, sir. If it is diffuse, less than 50% of glomerulus
Less
is
than. Diffuse means?
more than 50%. Focal is less than 50%.
When will you call it crescentic?
When there is at least 2 layers of parietal epithelial
When
cell,
will you define this as a crescentic GN?
there is more than 10% of glomerulus.
More than
10%.
No, no.
Initially it was
Defining a
25%.
crescent. But definition of crescentic GN.
Yeah. What
what
percentage
percentage
of
of
glomeruli?
glomeruli should be?
To show crescents, to qualify that as a crescentic
25%.
GN.
No,
And 20%.
50.
50.
50 to 60%. Immunofluorescence in this boy?
There will be starry sky appearance and basically IgG. There will be granular pattern, ma'am.
Coarse
What
Coarse
are
granular.
granular.
what are the patterns?
Garland pattern, starry sky pattern. Starry sky pattern will be.
If you do the biopsy in the resolving stage of the disease, what is the pattern called?
Usually during resolution there will be Garland pattern, ma'am.
Hmm. Resolution phase, what will be the pattern? Mesangial pattern, isn't it? Mesangial pattern. Only C3 in the mesangium. Hmm. Where is the typical site of immune deposition?
Both subepithelial and subendothelial
What is
humps.
subendothelial? For IRGN?
Subepithelial humps, ma'am. Yes.
Only subepithelial. Okay.
What is
If you have a
experimental?
normal C3 in the patient with acute nephritic, what are the causes?
Normal C3 with.
Normal C3 with RPGN. DDs.
Just your differential diagnosis.
IgA
Ah.
vasculitis.
Vasculitis, any
Ah.
other?
Um,
Crescentic
Secondary
GN with
TM.
normal C3. What are the other classes of crescentic GN?
Autoimmune.
And
Immune complex.
immune complex with
With-
another. What is the class 1?
Anti-GP.
With a normal C3, isn't it?
Yes.
Is complement involved in IgA?
Yes, ma'am. The theory now is because of alternate complement pathway.
For IgA.
IgA.
Is it alternate complement pathway?
Yes.
Or what is your opinion? Mannose binding lectin pathway is involved.
That is the third pathway. Classical, alternate, lectin.
NDL. What is IgA dominant IRGN?
So supposing the, okay.
It is most commonly seen in elderly population. Staph aureus is most common cause,
Elderly staff,
and there will be significant history of alcohol intake, or there will be other comorbidities,
Diabetes.
diabetes, and
how will you differentiate an IgA nephropathy from an IgA dominant IRGN, histopathologically?
In histopathology, there will be exudative this endocapillary hypercellularity in IgA dominant IRGN, whereas in IgA nephropathy there will be mesangial matrix expansion.
One.
And whereas in immunofluorescence, there is
Neutrophil infiltration?
Neutrophil infiltration is common in IgA dominant IRGN,
Okay.
whereas it is absent in IgA nephropathy.
3.
In
Site of immune deposition?
Site of immune deposition in IgA dominant IRGN, it will be subepithelial, whereas in IgA nephropathy, it will be mesangial.
These are the differences between
If
these two.
C3 continues to be low,
After 12 weeks, then we have to contemplate a biopsy. As such, in IRGN, renal biopsy is not a recommended line. If C3 continues to be low, we can, more than 12 weeks, we can contemplate a biopsy and look at other,
what do you think?
there can be C3GN, or there can be atypical HUS.
What is the experimental model?
Atypical HUS 12 weeks, no complaint.
Like presenting as IRGN and
C3 glomerular.
C3.
Hydrate.
Yes,
C3GN, LPGN.
MPGN
Experimental model.
of IRGN.
Any other condition where you have a persistent low C3?
Lupus.
She mentioned earlier. Agnes talked about 3 varieties of RPGN, GBM,
Yes.
POSI,
Yes. Yes.
complex.
Yes.
So, what is the worldwide pattern and the Indian pattern? Which one is the commonest in India, from the Indian literature, whatever the data is there?
Yes.
And is it the same in the Western world, or is it different?
It is different, sir. In India, most common cause is immune complex mediated GN. There was study conducted in PGI Chandigarh. They showed that immune complex mediated GN is most common, and whereas worldwide anti-GBM is like quasi-immune is more common. Quasi-immune is more-
Anti-GBM is the rarest all over the world. Only about 5%. Not too much.
If you
And the
talk
study was not only from PGI, there's a study from Pondicherry also. Shrijit.
She's sir.
If
So,
you're thinking of a POSI immune,
Yes.
is there again a difference in geographic difference?
I'm not sure.
Anchor immune. Is there a difference?
Time
If we
over?
have the anchor
Next case.
immune.
Next case, second case.
Second.
This time not for 10 minutes more?
No, madam.
Short
Short
case.
case is for 25 minutes, madam.
okay.
2 short
Okay.
cases.
The postgraduate should know the experimental models of common glomerular diseases and etc.
Serum sickness.
Second case.
Just one last question.
Yes,
is this.
yes.
You said immune complex is the commonest.
Yes, yes, yes.
That's right. So which immune complex is the commonest?
IgA nephropathy.
IgA. That's an important point. That's the commonest cause of mesenteric GN.
Yes.
Yes.
My second short case, Mr. P, 71-year-old gentleman, ex-superintendent in agriculture, 71 now. He worked as a ex-superintendent in agriculture department, hailing from Nizamabad. Date of admission is 7th of August. I examined him on 17th of August. Informant his son and his wife. Chief complaints, he presented with chief complaints of loose stools and vomiting since 15 days. And pain abdomen, turbid CAPD fluid since 11 days, and also excessive hiccups. Shortness of breath and anasarca since 5 days. I would like to date back my history 10 years ago, where he was diagnosed with diabetes mellitus, for which he says he took indigenous medications for treatment for almost about 5 years. Asymptomatic throughout, however, during this period, after which he developed loss of appetite and anasarca, in view of which he was evaluated at a local hospital and was told to have deranged renal function in the form of increased serum creatinine values and reduced size of kidneys. He was also told that he was losing protein in the urine due to diabetes, for which he was prescribed some oral medications. He then visited our hospital for second opinion, where he underwent renal biopsy. 5 years ago. He then visited our hospital for second opinion, wherein he underwent renal biopsy and was told to have diabetes changes in it. He was also advised to undergo AV fistula creation for future requirement of dialysis and was discharged. 4 months after which he again presented with anasarca, shortness of breath, increased blood pressure, in view of which he was initiated on hemodialysis via right internal jugular vein non-tunnel catheter for 1 month, followed by left brachiocephalic fistula, which he received dialysis for almost about 2 years at Nizamabad Peripheral Dialysis Center thrice weekly. Patient also says that he had significant intradialytic hypotension episodes intermittently, and his intradialytic weight gain was around 2 to 2.5 kg, residual urine output approximately 100 ml. He was vaccinated for hepatitis B and remembers to have received all 4 doses. 2 years ago, he had secondary failure of left brachiocephalic fistula. It was then he presented to our hospital again. He underwent a right IJV non-tunnel catheter insertion. Meanwhile, during this period, considering his age and episodes of intradialytic hypotension, he was advised to undergo CAPD after counseling. So he underwent CAPD catheter insertion uneventfully 2 years ago, and he was initiated after 14 days of breaking period with 1.5%, 2.5% with 8 hours of well. He remembers his ultrafiltrate approximately to be around 1 to 1.2 liters. It was done by his wife. Then his residual urine output was nil. He remained asymptomatic throughout till now. Now he presented with complaints of 2.5 years now. Now presented with complaints of loose stool since 15 days, and it was water inconsistency, 4 to 5 episodes per day, and he remained symptomatic for almost about 5 days. There was history of vomiting since 15 days with 3 to 4 episodes per day, but there is no history of blood and vomitus, contained food particles, and it lasted for 5 days. After which he developed pain abdomen, diffuse in nature, non-radiating since 10 to 11 days, and he also noticed, and his wife noticed, that there was turbid effluent from CAPD since 11 days. He also gives history of recurrent hiccups. There is no history of fever, cough, no history of loose stools, constipation now. There is no history of altered sensorium or schisis. There is no history of swelling in bilateral lower limb. He was admitted with above complaints in our hospital on 7th. After battery of test, he was told to have infection in abdomen, in view of which he was initiated on intraperitoneal antibiotics. Meanwhile, his exchange was changed to 2.5% dextrose thrice daily with 6 hours of well. However, he was also given automated exchanges via cycler for 48 hours in view of reduced ultrafiltrate, which was approximately around 600 ml per day. Patient now complains of shortness of breath on exertion, no history of orthopnea, P&D, chest pain since 5 days. There is history of swelling in bilateral lower limbs up till knee, and there is also facial puffiness since 5 days. He also complains of intermittent cough without any expectoration. There is no history of fever, no postural or diurnal variation of cough. There is no history of swelling in genital area. There is no history of localized swelling in abdominal area, and there is no history of loose stools or constipation. Shall I summarize now? Significant positive history. There is a significant pallor and edema. Blood pressure is 130 by 80 millimeters of mercury in left arm supine position. There is a scar in both bilateral upper limb because of left BCA wave creation. In parabdominal examination, there is mild guarding with diffuse tenderness all over, and all areas move equally with respiration. There is CAPD catheter in situ just below the umbilicus. There is no organomegaly. Bowel sounds are heard. Other systemic examination is normal, except for respiratory system. There is no discharge from the exit site. There is no erythema or induration, and
What about the tunnel?
tunnel looks normal. No,
No tenderness over the
no
tunnel.
tenderness.
Exit
No
side is
induration.
normal.
Exit site is normal.
Any hernias?
No hernias in
Umbilical, inguinal.
umbilical, no hernias. Summarizing the case, 71-year-old gentleman, no diabetic since 10 years, significant history of indigenous medicine intake, presented with fluid overload, uremic symptoms 5 years ago, underwent
The summary should be in 3 to 4 sentences, not the entire history again.
Diagnosed case of
Ah.
end-stage renal disease due to
diabetic nephropathy, and initiated on hemodialysis initially, remained on hemodialysis for almost about 2 years.
does he have
And then
any
he was not evaluated then. No?
bilateral small kidneys?
Yes. And he was shifted to CAPD 2 years ago, and now he presented with loose stools, vomiting, and pain abdomen with cloudy effluent.
Diabetes, 10 years of diabetes.
Yes.
Kidneys were small at what stage? When was that?
Sir, after 5 years he presented, sir. For 5 years he has taken indigenous medications.
Then the kidneys were supposed to be small.
He-
How small, the size?
That he does not remember, sir. He does not remember.
But then a biopsy was done.
Yes, sir. Probably borderline size kidneys.
Yeah, so that's why they could be very small.
Yes, yes. Yes.
And what are the indications for doing a biopsy?
Yes. Atypical presentation, like if there is any microscopic hematuria, there is a rapid, sudden onset nephrotic range proteinuria, and absence of diabetic retinopathy, and if we are suspecting any other glomerular disease.
Absence of retinopathy in which type of diabetes?
This is with respect to type 1 diabetes, sir. Even then, 40% diabetes cannot have diabetic retinopathy. 60% it is.
In type 1?
Type 2, sir. Type 2.
Yeah, any other reasons for, you mentioned some of them.
Yes, sir. And other, if you are suspecting other glomerular diseases in, like if there is low C3, low C4, or rapid progression. Ma'am, by 15 to 20 years of duration of diabetes, patient's GFR will come down. Initially, if,
Type 2. Type is the natural disease.
it can be at,
It's not really,
it is for type 1.
that is for type 1.
Yes.
There was a long history of indigenous medicine intake, 5 years.
Yes, yes.
Right? So, do you think, although you have a biopsy later, which you said shows diabetic nephropathy,
Yes.
I would think even that might be an indication for doing a biopsy.
Yes, sir. Because it can cause membranous nephropathy because of NEL.
Any
And
problem?
Yes.
You come to that.
Indigenous medicine, what medicine? Did you just ask him?
he said he took some Ayurvedic and medications with some.
Membranous nephropathy and some MEL.
Yes, yes.
And she said MEL.
So, have you seen any reports of proven indigenous medicine or Ayurvedic medicine causing kidney problems? They are rare, not very common.
Yes,
So the
yes.
documentation is lacking,
Yes, yes.
most of them.
Yes.
But have you seen any reports of this kind?
From Chennai, there is one case report, sir.
What was the toxic component in
Mercury.
mercury? That could be one possibility. Any other?
Lead.
Lead. That's proven actually.
Yes.
There are cases of record.
Yes.
So that is what you should be aware of, because indigenous medicine intake is very common in India. The unfortunate thing is that we don't even investigate those patients, we just ignore that. And then estimation of lead is not available in most labs.
When do you suspect the lead as their cause for?
Adrenal gout, anemia with microcytes.
If there is significant drug-induced toxicity, what will be the difference in histopathology that we expect?
It will involve more tubular interstitium compared to glomerulus.
You said this patient had intradiabetic hypotension.
Yes, ma'am.
What do you think was that?
Probably because of long-standing diabetes leading to autonomic neuropathy, one. Second, it can be because of poor cardiac reserve. Or third, because of low, there is no restriction in salt and water intake, which is most common. And fourth, because of interdialytic increase.
Short and water intake will cause hypotension.
Yes, ma'am. Because it causes interdialytic weight gain, and then there is excessive fluid removal, and then
Say excess
removal.
Can a diabetes without this drug-induced toxicity have predominant tubular interstitial disease
Yes, ma'am.
without significant glomerular involvement?
Yes, ma'am.
What is that group called? What is the difference between diabetic nephropathy versus diabetic kidney disease?
Diabetic kidney disease, when we don't have histopathology evidence, and we are and the patient has the natural history of progression of diabetes, and then
What is diabetic nephropathy?
when there is histopathological evidence of diabetic nephropathy,
Are you aware?
um,
You heard of an harmonic exchange.
Yeah, you won't find it described in your recent textbooks. They have excluded it. But yes, it was described mainly as autopsy long ago. So vacuolar kind of tubular lesion.
If you see a nodular glomerulosclerosis in the biopsy, what are the other findings to be looked for to say this is due to diabetes?
ma'am, once we see
What is this
nodules,
tubular Armani-Epstein lesion? What are the other?
yes, ma'am. Then we do a silver stain, ma'am. If silver stain is positive, then we ask history of diabetes. Then, if there is no history of diabetes, it can be idiopathic glomerulo.
What are the other typical histological findings to be searched for?
MIDD.
Capsular drops, they are said to be pathognomonic of diabetes.
Hyaline caps and
drops and
capsular
fibrin
caps.
caps.
Patient is now 71, and of course, without this history of diabetes. Suppose you didn't have the biopsy at all.
He underwent renal biopsy when he came. Yes.
Supposing
Yes.
no biopsy was done.
Yes, yes.
To find out the cause of CKD, would you do any other investigation also?
Proteinuria.
That's fine, but that doesn't give you a final answer. Okay, supposing he was not diabetic.
FLC.
Not a diabetic.
Supposing he was not a diabetic.
At this age,
Elderly man with unexplained renal failure.
we want to rule out multiple myeloma. So,
Look for a monoclonal gammopathy.
monoclonal gammopathy.
So what investigation would you do for that?
Serum FLC ratio, protein electrophoresis of both serum or urine.
And you can do immunofixation also.
Immunofixation. Yes, yes.
Those three. You can choose 2 out of 3 if you want to save money. Very simple test of the urine which can also give you a clue?
Bell's-Jones proteinuria, sir.
Yeah, but you don't often do that straight away. What do you generally do?
The protein in dipstick it will be absent, whereas 24-hour urine protein there will be significant proteinuria discrepancy
Right.
between
So
both.
dipstick is insensitive to light chains.
Yes, yes,
And light chain proteinuria is what you will get in that condition.
yes,
And that will be picked up on the 24-hour urine protein,
yes,
but not on ACR.
yes,
ACR will be negative.
yes.
So that is the important investigation. And then of course you can do Bell's-Jones protein, urine electrophoresis and so on. So that's an important investigation to do in a patient like this.
Yes.
Now, this patient is now on CAPD.
Yes.
So why do you think this patient was put on CAPD?
One because he's elderly, sir, and
It's
he
not a good reason.
there was intradialytic hypotension, and there was,
Okay, anything else?
and he also because of poor cardiac reserve.
Has it been proven in
No,
Just
no,
only
sir.
hypotension.
No,
He
hypotension.
had one more reason.
Fistula failure.
Access failure.
So vascular access failure. Roughly what percentage of all CKD5 patients now in India are on CAPD? Can you give me just a rough figure, a guess?
CAPD penetrance into KRT program.
I'm not sure.
Any guess? Anybody?
8 to 10%.
Less than 5%.
I would agree with that. I don't know about the south so much, but it's down to just 5% in the north, because hemodialysis has become available everywhere, even in small towns.
Government sponsored.
Yeah, government sponsored, even in Himachal Pradesh where there was no hemodialysis earlier. So everywhere hemodialysis penetration has occurred. That's one main reason. Sorry, there's one more question regarding that only. When a family comes to you and patient has CKD5, you're counseling them about dialysis, and they ask you about CAPD versus HD, so what would you tell them about pros and cons of these two?
Like if elderly patient comes and he has other comorbidities and poor cardiac reserve, I would advise CAPD. And if a young population comes, I would prefer hemodialysis. One, because there is preserved cardiac function, and also because other comorbidities like diabetes are not there. Diabetes is not there, so there will be fistula maturation will be earlier compared to elderly, and
Any particular group in which you will definitely actively promote CAPD?
not mobile.
Not mobile, okay, anything else? Difficult to come to hospital, not mobile.
Multiple access failure,
Access failure is fine, that is applied to this patient.
Pediatric age group.
pediatric age group.
Pediatric age group, yes. One more at least. Some patients have ascites due to something else.
DCLD.
Chronic liver disease.
Chronic liver disease.
So those who have chronic liver disease and ascites, because what is the advantage of PD in there? It takes care of the ascites. Simultaneously, you're regularly
Yes.
draining that fluid also,
Yes.
so the abdomen doesn't remain over distended. So that's why it's a good option.
Any other benefits of CAPD over maintenance hemodialysis program?
Residual
Ah.
renal function will be maintained better, ma'am.
How do you assess residual renal function?
Actually, 24-hour urine pre-dialysis urea and serum urea with
Simple.
Simple
Practical,
test
daily
measure.
basis.
Quantification.
That's all. Quantification of urine.
Urine output.
Only. And how much? If it's below this much, you will say there is no RRF.
Sir, a minimum 400 ml is required to clear the osmotic loads.
Some people take 100, some people
200
take
ml.
200 maximum.
Maximum 200 ml.
200. So not more than. If it is less than that, your RRF is virtually zero. That's how you should assess. You don't need any sophisticated.
Any other benefit of CAPD other than preservation of urine volume?
The hemodynamic stability will be maintained,
Two, three.
ma'am. And the cardiac
Hemodynamic
Income
stability.
provides.
Okay, that already said.
Less risk of what infections?
catheter related.
There is here also.
That is more.
Endocarditis.
Any other viral infection which can be transmitted during dialysis, hemodialysis?
Hepatitis B and
Viral
hepatitis C.
contamination.
Yes, contamination.
And so I'm just coming back to that point briefly. When you guide a patient towards hemodialysis or CAPD, what else should you emphasize? It's a very important point.
The caregiver hand hygiene. And
That part is all right for prevention of infection. How fatiguing is the process of doing CAPD over a long period of time, both for the patient
yes,
and the caregiver?
yes.
When you do hemodialysis, you
Yes.
can do it 2 or 3 times a week, right? So you have 4 days in a week
Yes.
when the patient is free. He has
Yes,
no burden of dialysis.
Yes.
more.
Caregiver burden is less.
Whereas in CAPD, zero
Yes. Yes.
freedom.
Yes.
So look at the burden. It's exhausting.
Yes.
Dietary advice in a patient with CFP.
Because there will be loss of protein also from approximately 5 to 7 grams, sir. So it will be still more high.
Answer to the question,
Correct.
nutritional advices to a CAPD patient.
Uh,
How much protein, how much etc. That's all.
There will be additional 5 to 7 grams of protein loss.
What is the recommended protein intake for a CAPD patient?
1.2 gram per kg body weight.
It's 5.
Ah.
More than hemodialysis.
When was the latest nutritional guideline by Kedoki King?
2020.
2021.
Just one, I think we have finished the time limit.
How will you modify a CAPD prescription during an episode of peritonitis?
They are more prone for type 1 ultrafiltrate failure, so there will be rapid dissemination of
What's
rapid
the transporter
dissipation.
characteristics during an episode of peritonitis?
There will be rapid dissipation of that osmotic
What is the type of transporter status?
high transporter, ma'am.
Okay.
And
Why they become high transporter during peritonitis?
because of increased vascularity,
Okay, vasodilatation.
vasodilatation.
So what modification the prescription to be done?
So either I'll increase the tonicity of the fluid either by from 2.5 to either 3.5 or 4.5, or I'll increase the number of exchanges compared to the
What
dwell
should be
time.
the dwell time?
Dwell time should be less, ma'am.
Ah, that
Should be
should
approximately
the
2
modification
hours.
then.
Yes.
Dwell time should be roughly around 2 hours.
2 hours.
So
yes.
how will you give intraperitoneal antibiotics then?
Night dwell, ma'am.
Only the dwell with an antibiotic should have a 4 to 6 hours.
Yes.
All other dwell should be 2 hours. Or
Or ICOD extreme.
automated peritoneal.
Automatic citrus.
Why does it have to be a long dwell, Madam Said?
At least 6 hours is
Why?
the absorption of.
Of what?
I'm not sure.
Not sure. Anybody?
Antibiotic
What
dwell
types?
of 6 hours. Why?
See, you need time for absorption of the antibiotic from the peritoneal cavity into the circulation, right? What happens is that antibiotic goes into the circulation. During each dwell, it comes back into the peritoneum. That's how it treats the peritonitis. And of course, it stays in the circulation as well. So it needs that much time for absorption from the peritoneal cavity. If you give it in a short dwell, that antibiotic is going to, when you drain the dwell, the antibiotic will also go out with it, isn't it? So that's the reason for it. So if a patient is on automatic PD,
Yes, sir.
then what will you do?
Either I'll keep a day dwell, sir, or change to Icodextrin in day dwell, so that 6 hours of Icodextrin.
Either you have to do that or you give IV antibiotics.
IV antibiotics. Yes, sir.
You do that.
When will you think of removing the peritoneal catheter in the context of a bacterial peritonitis?
When there is resistant COPD peritonitis,
How will you define resistant peritonitis?
after giving 5 days of IP antibiotics, if the colony count is more than 10^9, it is defined as resistant.
Do you give
peritonitis.
antifungal prophylaxis for every bacterial peritonitis?
Yes, ma'am. Now it is recommended oral fluconazole, either 200
What
to
are the other
400
indications
milligrams.
for catheter removal?
Fungal peritonitis, resistant pseudomonal infection,
3.
catheter-related infection, associated with exit site or tunnel infection.
Exit site, only tunnel infection.
Tunnel infection.
Peritonitis associated with tunnel infection.
Tunnel
You have to
infection.
remove. Do you remove it for tuberculous peritonitis?
No, ma'am.